The anti-thyroid drug. Anti-thyroid drugs are mainly given in the treatment of hyperthyroidism. So in this, we'll have to stop the excessive secretion of the T3 and T4. So this anti-thyroid drug is also known as thyroid inhibitor. And these drugs are mainly used to lower the functional capacity of the hyperactive thyroid gland. Before moving to the drugs, that is anti-thyroid drug, first of all, we're going to see about the hyperthyroidism. What we're going to treat. So hyperthyroidism is nothing but the overproduction of thyroid hormone by an overactive thyroid. So whenever there is an excessive overactiveness of the thyroid, it is called as a thyrotoxicosis. So in the thyrotoxicosis, we'll able to see variety of symptoms. Whenever there is a group of symptoms, it is known as syndrome. So what are the symptoms that are able to see? Rapid heartbeat, sweating, anxiety, tremor, and so many. So why this thyrotoxicosis occurs? What are the causes? Mainly two causes are there. First one is a Graves' disease and second one is toxic nodular goiter. So apart from that, there are the other causes also, but mainly these two causes are causing the thyrotoxicosis in the patient. So Graves' disease, we already know about their pathophysiology. We already learned that in the first year. So in the Graves' disease, what happens exactly? Overproduction of thyroid hormone. So why there is overproduction of thyroid hormone? Because in that, the autoimmune system will going to get activated. Due to that, there is a production of IgG antibody, and these IgG antibody will going to bind over the TSH receptor that are present on the thyroid gland. After binding to that TSH receptor, they will stimulate that receptor. Due to overstimulation of the TSH receptor, there will be the production of the thyroid hormone, and that production will be the excessive one. So because of that, Graves' disease causing the hyperthyroidism. Next one is toxic nodular or multinodular goiter. So in that, there will be the lumps of the thyroid gland, and all these lumps are very functional, and that functional lumps will going to produce the excessive T3 and T4. In that, they are all are the independent of the TSH. They itself are secreting the T3 and T4 without permission of the TSH. Next cause is thyroiditis, means inflammation of the thyroid. So sometimes there will be the inflammation, and that inflammation may cause the leakage, and due to that leakage, hyperthyroidism can occur for temporarily. Next one is excessive intake of the thyroid hormone. If we are taking the excessive thyroid hormone, their side effects we are able to see as a hyperthyroidism. So all these are the causes of the thyrotoxicosis, and we're going to treat that thyrotoxicosis with the help of anti-thyroid drug. So now we'll move to the next part, which is called as an anti-thyroid drug. Before moving to the anti-thyroid drug, I would like to see the biosynthesis again, because our drug will going to target this biosynthesis. So we'll revise that step. So first step is iodide trapping. Who are trapping that iodide? The protein which is known as sodium iodide symporter. Okay, once iodine will enter, second step will start, which is called as synthesis of thyroglobulin. Okay, after that you can able to see secretory vesicles. They will cause the exocytosis with the thyroglobulin. Then they will enter into the lumen of the follicle cells. Once they will enter, there will be the third step, which is called as oxidation of iodide. In that you can able to see thyroid peroxidase and hydrogen peroxide. These two are involved. You have to remember these names, thyroid peroxidase, because our drug will going to act over here. Again, you can able to see this thyroid peroxidase acts in the oxidation as well as in the coupling part. Okay, so next, the fourth step is iodination of the tyrosine. In the iodination of the tyrosine, there will be the formation of MIT and DIT. This step is also called as iodide organification. Remember this step also. These are also important. for our mechanism of action. Okay, after that we will able to see there is a next step which is called as a coupling of T1 and T2, means there is a formation of T3 and T4 with thyroglobulin. Then next step you can able to see pinocytosis and digestion of the colloid, means these thyroglobulin with T3 and T4 now will enter into the again back into the follicle cell, epithelial cell, and after that it will combine with the lysosome, and after getting combined with the lysosome they will get broken down because of enzymes which are present in the lysosome, and they will release the T3 and T4. With the T3 and T4 again they are releasing MIT and DIT also, and these MIT DIT will release the iodine, and that iodine will reutilize. So after that next step is secretion. After secretion means due to T3 and T4 lipid solubility they will enter into the bloodstream, and after entering into the bloodstream they will reach to the target organ with the help of transporter, and in the tissue it will get converted into the T4 to T3. You have to remember this step also, which is called as a peripheral conversion. T4 to T3 with the help of enzyme deiodinase. 5-deiodinase enzyme which is responsible for conversion of T4 to the T3. So we revise biosynthesis of the thyroid hormone again. Now we'll move to the drugs which are based upon this biosynthesis of thyroid hormone. Now we're going to see anti-thyroid drug classification. Very important classification. Sometimes question can be asked like classify anti-thyroid drug and write the mechanism of any one of them, like ionic inhibitor, hormone release inhibitor, or hormone synthesis inhibitor. So all these are the classes that are involved in the anti-thyroid drug. So first class is hormone synthesis inhibitor. Here you can able to see synthesis word. So it will going to, this drug will going to act in the synthesis part. So what are the drugs are there? Propyl thiouracil, and next one is carbimazole, and in bracket you are able to see methimazole. So why that are written in the bracket? Because carbimazole once enter into our body, it will get converted into the methimazole, and this methimazole will going to act on the target. Next one is hormone release inhibitor. Here you are able to see iodine, sodium iodide, potassium iodide, and another one is organic iodine. So all these are the iodine used in the hormone release inhibitor. We're going to see in the detail. Next one is destroy thyroid tissue. As we know that radioactive iodine, these radioactive iodine isotopes are given over here, like iodine 131, iodine 125, iodine 123. Out of that only iodine 131 is used for the treatment, other are used for the diagnostic purpose. Next one is inhibit ionic trapping. So trapping word is there, so you have to remember about the iodide trapping. So these are all are the drugs are working on the that step which is called as a iodide trapping. So which are the drugs are there? Perchlorate, nitrate, thiocyanate, all these are the ions that will going to work on the that iodide trapping step. And the next one is beta blocking drug. So why beta blocking drugs are here? If you remember about the thyroid hormone action in the cardiovascular system. So in the cardiovascular system, what happens? Due to the thyroid hormone, there will be the upregulation of beta receptor. So whenever there is a excessive T3 and T4, there will be the upregulation of the beta receptor, as well as there are the other sympathetic activity will also get activated because of T3 and T4. To block this activity, we are giving the beta blocking drug with the other anti-thyroid drugs. So here you can able to see one note is there. Compound in group 1 and 2, these two groups, which is called as a goitrogens. Because if we are giving these drugs in excess, it will cause a problem which is called as an enlargement of the thyroid. And why this enlargement of the thyroid will occur? Because this drug will going to stop the synthesis of T3 and T4. If there will be the decrease in the T3 and T4, you have to remember about the regulation. What will happen? There will be the stimulation to the hypothalamus, then pituitary gland. Pituitary gland will going to release the excessive TSH. If there is a excessive TSH will get produced, that TSH will going to bind on the thyroid gland TSH receptor, and after binding to the TSH receptor, the excessive TSH stimulation will occur, and that will cause the enlargement of the thyroid gland. So this is what the reason why they are causing the enlargement of the thyroid gland. Now we are going to see the first class of these antithyroid drugs. This is also known as thioamides, also known as hormone synthesis inhibitor, also known as antithyroid drug. All these are the antithyroid drug, but at the start only this drug were considered as an antithyroid. But later on these other classes will also included into the antithyroid drug. So here we're going to start with the thioamides. So what are the drugs are involved? Methimazole, propyl thiouracil, and we already seen carbimazole producing the methimazole as a active metabolite. So now we're going to see start with the mechanism of action. So in the mechanism of action, how they are going to work, how they will going to inhibit the hormone synthesis. So you can able to see in this diagram, they are inhibiting the thyroid peroxidase. So first way, by inhibiting the thyroid peroxidase, as we know thyroid peroxidase were involved in the iodide oxidation. Second one, they are also blocking the iodine organification. So in the iodine organification, again thyroid peroxidase is involved. So they are blocking both the step, and due to blocking of the both the step, there will not be coupling of the iodotyrosine, and there will be the inhibition of T3 and T4 production. Again, this propyl thiouracil have additional features which is called inhibition of the peripheral deiodination. As we discussed the last step, whenever T4 enters into the tissue, specific tissue, they will get converted into T3. So this propyl thiouracil also have this another mechanism by which they will going to reduce the conversion of T4 to the T3. As we know, T3 is a potent one. They will going to act on the receptor and will going to show the action. And because of this extra features, they contribute to its antithyroid effects. So where we are using these drugs, mainly these drugs are given in the diseases which is called as a Graves' disease. Another one is toxic nodular goiter. Even these drugs are given before the surgery, so they can stop the excessive secretion of T3 and T4, and they will able to do the surgery. Again, these drugs are used in combination with the radioactive iodine before giving the radioactive iodine to that patient. Next one, we're going to talk about the pharmacokinetic. Absorption of the thioamides. So all the antithyroid drugs quickly absorb and given orally. So once they will enter into the bloodstream, they are get widely distributed in the body, as well as they are able to enter into the milk and cross the placenta. So in the pregnancy, they may cause a problem to the fetus. Next, in the metabolism, they are metabolized by the liver. Excretion is done by the kidney. And they have one more features, like whenever they enters into the thyroid gland, it will get concentrated into the thyroid gland, and it will remain there for the longer time than that of the plasma. And we already seen about the carbimazole, and once enter into the body will get converted into the methimazole, and this methimazole will going to act as a active metabolite. And one more feature to this methimazole, which is a longer acting than that of the propyl thiouracil. Because of that, dosing interval will get reduced. Next, we're going to talk about the adverse reaction. If we are giving this anti-thyroid drug over treatment, there will be a problem like hypothyroidism and goiter can be seen. But on discontinuation of this drug, again, that can be reversible. Other side effects are also seen like GI intolerance, skin rashes, joint pain, as well as liver damage, taste, fever, loss of hair. All these are the infrequent side effects that are seen with this drug. Rare but serious adverse effects is agranulocytosis. It is very dangerous when it occurs. So these are also reversible. If we are stopping the drug, again we are able to see reversible effect. Now we'll see about the difference between propyl thiouracil and carbimazole. From exam point of view, it is important. In the first point, there is a structural difference between both the things, but it have the same mechanism of action. So in that, propyl thiouracil having the thiourea into their structure, carbimazole have the imidazole ring into their structure. Next point about the potency. Both have the difference in the potency. Carbimazole is more potent and propyl thiouracil is less potent than that of the carbimazole. Again, next point, there is a difference between the plasma protein binding. Propyl thiouracil having the high plasma protein binding as compared to carbimazole. Next one is T-half. Both the drug have the different T-half. Next one is dosing. As we know, single dose acts for the 4 to 8 hours. So after 4 to 8 hours, we'll have to give the another dose to maintain the to decrease the T3 and T4. In the carbimazole, we need not to give multiple doses. Single dose can work for 12 to 24 hours. So in the next one, you can able to see about the active metabolite. Carbimazole get converted into the methimazole. So because of that, it is an active metabolite. As such, propyl thiouracil will not able to get converted into any other active metabolite. But propyl thiouracil have an extra feature which is called as a T4 to T3 conversion inhibition. But carbimazole is not able to do the same thing.